We are so excited to have everybody here at our patient meetup. My name is Dana Dayton, and I am the Director of Communications and Engagement at the Melanoma Research Alliance, and I will be moderating this webinar. First, we'd like to welcome all of you and thank you for joining. We also want to thank you for your flexibility. Some of you had signed up to participate with us last week, but here we are this week, and so we're so glad that you are with us. Last week, I was going to mention that June was Cancer Immunotherapy Month, but now that we are one day away from that, it doesn't quite seem as important, but I do want to just mention it because I know many people on this call are recipients of immunotherapy, and it's also a perfect time to celebrate the science that is driving all of these improved therapies, some of which we're going to talk about today. So anyway, once again, thank you for joining. Today's MRA Meet-Up, Oncolytic Immunotherapy Clinical Trials and the Emerging RP1 Treatment, is another in a series of webinars designed to engage, educate, and most importantly, empower patients and caregivers. You can visit the curemelanoma.org blog on our website and click on Patient Webinars tab to see a library of our previous webinars. Before we get started, I have a few housekeeping items to review today. By joining this webinar, you understand that this will be a public event and recorded as a resource for others that will live on the MRA website. Portions may also be shared via MRA media channels. The content should not be used as a substitute for professional medical advice, diagnosis, or treatment. Please consult your healthcare provider about any questions you may have regarding a medical condition. It's on or off camera and how you would like your name displayed. Feel free to use your first name only or whatever you are most comfortable with. Please keep your line muted and others silenced for the remainder of this webinar. Should you come off mute to ask a question, please use the raised hand feature on Zoom and we will do our best to call on you. Please be respectful of the experiences, opinions, and questions of others. And now we get to move on. It is my sincere pleasure to welcome our expert, Dr. Yana Najjar, who is a translational investigator and cutaneous oncologist at UPMC Hillman Cancer Center in Pittsburgh, Pennsylvania, where she also is an associate professor of medicine and director of the Clinical and Translational Research Center. Dr. Najjar specializes in the treatment of advanced melanoma, focusing on anti-PD-1 resistant melanoma and rare melanoma subtypes. Using a bench-to-bedside approach, she has developed multiple investigator-initiated trials that aim to overcome mechanisms of resistance to immunotherapy. Her lab is focused on various correlative analyses from investigator-initiated trials. And special thanks to Renee Orsioni. She is our MRA Associate Director of Comms and Engagement, and Yasmin Idrisi, our Digital Media Intern, both of whom make this webinar possible and have helped us organize everything. Thank you both. Now, let's get started. Dr. Najjar, first of all, would you like to add anything to your introduction?
Hi, everybody. Thank you so much for spending part of your afternoon with us. As Dana mentioned, and thank you for the kind intro, Dana, I'm a medical oncologist at the UPMC Hillman Cancer Center, and I'm very, very focused in melanoma. It's, with few exceptions, the only cancer that I treat there. And so I am well and intimately acquainted with not just the standard of care landscape, but of course the clinical trial landscape and developing therapies in this space. So thanks for having me.
Thank you so much. So it's really interesting that this is like your primary focus as an oncologist. Can you please tell us a little bit about what drew you to the melanoma space and, what got you here?
What drew me to the melanoma space was very much my interest in immunotherapy. So I moved to the United States from my home country with the express purpose of becoming an expert in immunotherapy after medical school because we were just starting to learn about all of these amazing targets. We were starting to learn about PD-1 and PD-L1. And so I did my postdoc planning to specialize in oncology in a disease where I thought immunotherapy would be of utility. And as you know, this audience doesn't need telling, we really saw that sea change and that paradigm shift happen in melanoma. So as I did my postdoc and as I did my residency and as I did my fellowship, it became very clear that melanoma was leading the charge with immunotherapy. As you know, the first immunotherapy was approved in metastatic melanoma. The first two combinations have been approved in melanoma. The only disease state where we use LAG-3, for example, adjuvant therapy for stage 3, adjuvant therapy for stage 2, the first neoadjuvant phase 3, the first cell therapy, the first bispecific, et cetera, et cetera. And so melanoma is a very good model for the
Hmm.
development of immunotherapy, which we have been so privileged to be successful in. And we now see survival outcomes that I sincerely never thought I'd see in my lifetime. And that's just been incredible. It's been an incredible time to be in this field.
Thank you. Yeah, immunotherapy has definitely been a game changer. And I know for many people that have been diagnosed recently, their outcomes have been so much better than they would have been, just 12 years ago or so. So we're so fortunate to be where we are, but we also recognize that not everybody's needs are being addressed. And now we're starting to look at sort of, the next step in immunotherapies. And what we'll be discussing today is actually oncolytic immunotherapies. This type of therapy may be less known amongst the melanoma community because it's so new. So we would like to start with some basics. First, what are oncolytic immunotherapies? How do they work? And how do they differ from the immunotherapies that most of us already know about that are currently, part of the standard of care regimen in advanced melanoma?
I will answer your questions, Dana, but I just wanted to say I couldn't agree with you more. If we all sit around as melanoma specialists and as a community and we say, oh, great, we have 50% survival at 10 years, 43% melanoma, or 55% melanoma specific survival, 43% overall survival at 10 years after Ipi-Nivo. That's great, but the fact of the matter is 50% of patients have still been failed by the treatments that we have, and that's really where the work needs to be done. So I just wanted to say there's a lot of work to be done, and we are well aware.
Yes.
To answer your question, what is oncolytic immunotherapy? It is in many ways not a new concept. So oncolytic immunotherapy really refers to a type of cancer treatment whereby we are injecting a virus into a tumor, hoping to do two things. One, hoping to kill the tumor cells directly. And we know that when tumor cells die, they release different particles, what we call antigens, and different proteins into not just the environment of the tumor itself, but also into the bloodstream. And so this allows us to do the second thing, which is to activate the immune system. Now, we have become more sophisticated as a field, and the oncolytic immunotherapies we have now um, are engineered or modified to make them more potent in killing the cancer cells, but also more capable of activating the immune system. If you look back historically, this idea of inducing infection to elicit an immune response and an anti-tumor response is not a new one. William Coley did this in the 1800s with Coley's toxin, and there are many, many examples of bacteria and of viruses that have been attempted to be utilized in this way. We are now in an era where we are able to modify the viruses to make them do what we want them to do safely and more effectively. So I hope that answers the first question of what is oncolytic immunotherapy. How does it vary from what we have? Well, what we have in the clinic are drugs that are monoclonal antibodies. It's basically a protein that binds different targets on different immune cells. And we have antibodies to PD-1, to CTLA-4, to LAG-3. Those are the big three in the clinic.
Hmm.
But they all bind immune cells. Oncolytic immunotherapy is an engineered virus that infects the tumor cells specifically in a very targeted way that leads to death of the tumor cells and activation of the immune system. So mechanistically, it's very different.
Great, thank you. That was really a fantastic explanation. Um, so today we're going to be talking about even something more specific in the oncolytic field. We're going to be talking about Ignite-3, the clinical trial. Can you please tell us briefly what the trial's goals are and how someone could determine if they're eligible? Um, I know they're still enrolling patients, and this might be of interest to people that, really are looking for options.
Yeah, absolutely. And I think, Dana, before I speak to that, if that's okay with you, I think a little bit of context would be helpful. Is
Sure.
that all right? Okay. So, in the current paradigm, when we see patients with advanced melanoma in the clinic, we know that we're going to start off treatment with immunotherapy. And we know that more often than not, we're starting with a doublet of immunotherapies, hitting two different targets instead of just one. And that works quite well for up to half of patients. But as we said earlier, that means, of course, that there are half of patients who are not getting the benefit from these drugs that we would hope. This population is a population that has limited options. And I think that's very
Yeah.
important to understand to contextualize the importance of Ignite-3.
Yeah, thank you.
And the options for a patient really depend on what they got first. And I won't belabor all of that, but I'm happy to speak to it if it would be helpful down the line. So in our clinical decision making, we think very carefully about what we call front line or first line that the patient
Mhm.
received to inform second line. And if you already got ipi-nivo and you don't have a BRAF mutation, options are not great. There's Amtagvi, which is a very good option for a select number of patients because it's a very difficult regimen. We do it all the time, but we think very carefully about the patients for whom it's appropriate. You have BRAF MEK targeted therapies, about 40% of patients will be eligible, but while those drugs work very well, they don't have the durability that we would hope for. So, all of that to say, if you are not in the 50% who is having a good response up front, there really is a lack of options of what to do next. And so this is where Ignite-3 comes in. And Ignite-3 is testing an oncolytic immunotherapy, as we were just talking about, called RP1. The scientific name, and I hope I don't stumble on this because I often do, is vusolimagine odurparepvec. So I just call it RP1.
Great.
And it is a modified HSV1 virus. And the clinical trial is a phase 3 trial, meaning we've already established safety and some efficacy in earlier phases. And this is the big study where we are comparing the oncolytic immunotherapy plus standard immunotherapy versus standard treatments that would otherwise be available to us in the clinic. For patients to be eligible, they had to have had progression of disease of their melanoma on their frontline treatment regimen. And if they do have a BRAF mutation, they had to have received prior BRAF plus or minus MEK targeted therapy. The trial is actively enrolling, as you alluded to, Dana. This is an international
Mhm.
trial, um, and we have enrolled patients at our site. Many, many sites across the country are doing the same. And you'll notice I said earlier that the virus is injected into the tumor. So one of the most important criteria for eligibility, other than the ones that I outlined, of course, are that a patient has to have an injectable tumor. And this is, I think, another place that oncolytic immunotherapy is starting to distinguish itself. We used to inject oncolytic virus into superficial tumors only. There is one oncolytic virus that is approved in the United States for patients with unresectable melanoma, and that's TVEC. And TVEC is injected in a very targeted way into superficial or palpable tumors. With RP1, we know that we can inject it not just into the superficial tumors, but also into deep, what we call visceral within organs tumors. Now, of course, you're not injecting into the brain, for example, there's a lot of nuance there, but one of the key things is that the patient has to have an injectable tumor. And
Mhm.
they do permit enrollment for patients with acral melanoma, which is, albeit a rare subtype, but it is a subtype of cutaneous melanoma. But patients with mucosal melanoma are excluded. Patients with ocular melanoma are excluded, which I clearly would argue is to the detriment of all of us in the field, but th those are the eligibility.
Great. Thank you. That's really good to know. So you touched on, the viral aspect of this a little bit, and it's an RP1 is a new biologic, and it's a modified herpes simplex virus. Is that right?
Correct. HSV1, yes.
So, can you please explain what the herpes simplex is and how it is used in these investigational therapies?
Yeah, absolutely. So herpes virus is probably exactly what you're thinking of. It's the herpes virus, oral herpes, genital herpes.
Mhm.
These are ubiquitous viruses, but this uses the backbone. This is, to be very, very clear, not going to cause herpes. There has not been a single report, to my knowledge, of anybody, be it a patient or a caretaker or a healthcare provider, becoming infected. So that's just, I want to get that out of the way because it's the first thing I tell
Thank
my
you.
own patients. So it is a proprietary strain of this HSV1 virus that has been selected for its potency in infecting tumor and in killing tumor. And then it's been engineered, to my mind, in two ways that really set it apart. So they have introduced transgenes. So I don't want to be too technical, but I want to try and explain. So transgenes are when you are introducing a gene that is not originally in an organism to the organism. And one of the transgenes that's been utilized is the GalV-GPR transgene, and that allows for more potent tumor cell killing. And then you also have GM-CSF, which is very well established as an immune stimulator.
Okay, great. Thank you. That's very helpful. Um, so it is injected, like you said. Um, who usually handles the administration of the treatment to patients? And do patients have to come into the clinic? Is it like an infusion type of situation or just to the doctor's office?
So in the Ignite 3 trial, which we were discussing, patients receive treatment with RP1 and with nivolumab. And the nivolumab is administered every 2 weeks, and that's in an infusion and an
Mhm.
IV infusion. The RP1 is injected into the tumor. Depending on where the tumor is, it is done either by the medical oncologist. I have done it more times than I can count. It is very doable. And it can also be done by a physician assistant or a nurse practitioner in the clinic who is certified to do that. Now, if it is a deeper lesion, meaning I cannot see it with my own eyes, I cannot feel it with my hands, then it is done by interventional radiology. And what that means is that the patient goes somewhere that they can have direct visualization of what they are injecting, be it with ultrasound or CT. And that's, of course, for patient safety because you don't want to inject anything you're not injecting. And one thing I want to also point out is I know that the idea of having a tumor injected, of course, is scary for a lot of people, very understandably. And what we do is we numb the area with a topical numbing cream about 20 to 30 minutes before we proceed for the local injections in the office. And in my experience, knock on wood, patients have told me that they've really been totally fine. I mean, I'm sure it's not fun, but they have told me that they are not in pain and that it is more tolerable than they anticipated it would be.
That's really great to hear. Now, what if people have multiple lesions? Can you treat multiple spots at once?
We think very carefully, Dana, about which lesions to inject. Without getting into the weeds, but I'll get into the weeds a little bit. We know that the more sites you inject, the better. And I think scientifically, that's very intuitive. You know, we're talking about killing the tumor cell, releasing the antigens or the proteins from the tumor, activating the immune
Right.
system. The more times, the more places you do that, the more likely you are to really hit the secret sauce if you will, of activating the immune system. Not all tumors are the same. Certainly not
Right.
all tumors within one patient are the same. And so when you inject different tumors, you are in principle releasing different tumor antigens, you have different immune cells in the tumor environment, etc. So yes, the short answer is you can inject more than one at one time. We think very carefully about what to inject. And over time, it's an iterative process. We think carefully about what to inject next. What I inject the first time is not necessarily what I inject the second time, etc.
Thank you. So I imagine all of these injections really do contribute to a better systemic response, hopefully.
It would seem that way because we saw a poster at ASCO, which is our big oncology meeting, less than a month ago, suggesting that, and this has been shown before, but the first thing I want to touch on is we know that if you are injecting deep or visceral sites, meaning in organs, you are more likely to have a favorable response than if you are only injecting superficial lesions, number one. Number two, the safety issue is a very big one. Many people had said, and certainly I was amongst them, how are we injecting into the lung? For example, injecting into the liver is very well established. We've done it many times. Injecting into the lung, maybe less so. But we saw safety data at the recent ASCO meeting I was alluding to, whereby it appears so far, knock on wood, that this is really quite well tolerated in a very robust cohort. No bleeding events in the liver, no, not no, but very few instances of a collapsed lung, which is a risk anytime you are injecting into the
Sure.
lung. So yes, we know injecting deeper is better. Not only deep tumors, certainly. We also inject superficial tumors and have seen responses there. But I think targeting the heterogeneity of the patient's disease at different sites is a good thing. And so far appears to be quite safe, even with visceral injections. Now, of course, a lot depends on it's operator dependent, of course. You want an interventional radiologist who has done this before, but that goes without saying.
Well, I'm sure there are trickier spots than others, like you already mentioned, especially if they're more internal. And I'm sure that even with interventional radiology, like there is some strategy that really has to be incorporated to make sure you're hitting the most, I don't know, productive spot.
Absolutely. I look at the scans with my interventional radiologist myself, and I say, and for me as the oncologist, I have the privilege, if you will, of understanding the kinetics of the disease. And so I can say to the radiation oncologist, excuse me, interventional radiologist, this tumor hasn't been changing. I want to go after the one that's been changing. Something here is different. And so I have that vantage point, right? Because I've been taking care of the patient all along. And so they then tell me whether or not it's feasible and whether or not it's feasible more than one time if we think it should be done that way. And of course, what's the risk of the injection? If the interventional radiologist says, sure, I could get it, but I'm twitchy about it, then I say, well, then let's look for something else, of course, because safety is the first thing.
Absolutely. Absolutely. This sounds all just so encouraging and certainly beats, some of the other, older drugs that people would have to endure, if they have failed, first line or, anything else. So I imagine people are wondering, okay, like what exactly is the eligibility criteria or what might prevent me from joining this trial? Can you speak a little bit to that, please?
Of course, of course. So it's a phase 3 trial, so it's quite large. I think the goal is to enroll about 400 patients. And there are clear eligibility criteria, of course. And in broad strokes, patients must have received prior immunotherapy with both, I should say this because it's important, with both IPI and NIVO. So, or in other words, maybe I shouldn't say IPI NIVO, but with both PD-1 blockade and CTLA-4 blockade. So a doublet. And
Hmm.
that's a pretty strict criteria. And I think that's really good as an investigator because if you were to ask me what do I think is the best front line, I think I could successfully argue that it's Ipi-Nivo. That's maybe a conversation for another day, but they set the bar high, which I think is very important. I really
Yes.
dislike when trials set the bar low on purpose, you know? So the bar is set high, and patients must have received prior anti-CTLA-4, anti-PD-1, unless as a physician, I don't think the patient is a candidate for anti-CTLA-4, but that has to be very clearly documented. If they have a BRAF MEK mutation, a BRAF mutation, they must have received a BRAF inhibitor with or without a MEK inhibitor. And they must have cutaneous melanoma, allowing acromelanoma also, that is not excluded. And of course, they must have injectable disease, at least a centimeter lesion for the injection.
Great. That's really very helpful. And are there any other physical conditions that, could um, inform this decision, like, heart disease or diabetes or anything like that?
I wouldn't worry I wouldn't worry about diabetes or heart disease. I mean, of course, needless to say, every time we assess a patient in clinic, we take a very, and this is
Hmm.
when I say we, I mean oncologists, we take a very thorough medical, surgical, social history. But if somebody is diabetic or hypertensive or has heart disease, as long as they're not in heart failure, that's really not an issue. And I think part of the reason is that this regimen seems to be pretty well tolerated. The rate of what we call grade 3,
Calling
4 or
East
more
Summer.
severe toxicities
Our office
in
hours are Monday through Friday, 8 a.m. to 5 p.m. Pacific Time.
Yep.
If you know
I
your
think
party's
maybe
extension.
if one of our participants can please mute their line, that would be great. Thank you.
So the rates of more severe toxicity that we've seen in earlier studies with this agent are just under 13%. To put that in context, the rates of grade 3 to 4 toxicity with anti-PD-1 monotherapy is between 10 and 15%. So the combo of RP1 plus anti-PD-1 certainly is not more toxic than anti-PD-1 alone. And to my mind, as an oncologist, this very much sets it apart from my other options in the second line plus setting. My only standard of care option for somebody who has failed ipi-nivo that I think might give them some benefit if they don't have a BRAF mutation is Amtagvi, where the objective response rate, meaning shrinkage of tumors of at least 30%, is 31.4%. So it's about 1 in 3 odds of it helping, and that's great if that patient is a 1 in 3. But I'll tell you what, 100% of patients are going to have severe toxicity because of the chemotherapy associated. So a lot more people are candidates for this combination than others
Mhm.
that we have in this clinical setting of post-immunotherapy, where the immunotherapy, and I really am a big stickler, as I'm sure you guys are. It's not that the patients failed immunotherapy, it's that the immunotherapy failed the patient. And what we're now trying to
Yeah.
do is to do better by the patient. And I'm cautiously optimistic that this might be one of the ways that we're going to do that.
That is so exciting. I think a lot of people are going to be really excited that, this could provide an avenue for them. So thank you for explaining all of that. It's really, really hopeful. Are you hearing from any of your patients right now that are enrolled in the trial about like how it's going for them? Like what has it been like? Have they noticed a difference? Are they feeling better right away? Are they feeling worse after the injection? Anything like that?
So, because it's actively enrolling, I'll try not to get into details, but the patients that I've put on it have done by and large very, very well, fortunately. And I had a patient who told me it's a miracle, and I said it's not a miracle, it's science. And he always comes with a friend of his who's a priest, and the priest really chuckled at that. And or I said it's a miracle of science. He had this
Yeah.
huge tumor behind his ear that is gone, and it's changed his quality of life, needless
Wow.
to say. Um, and I have yet, famous last words, but I have yet to have anybody run into major side effects. And that really speaks to the data that's been disclosed so far. I didn't expect to. Some patients have told me, I feel like I have chills. I feel like I'm coming down with something for a day or two after the injection, what we call in the clinic constitutional symptoms.
Mhm.
This is suggestive of just an overall inflammation in the body, which is not surprising. But from what my patients tell me, it's very tolerable to them and it resolves quite quickly.
That's fantastic. It sure beats some of the side effects from chemotherapy and other um,
There's no
regimens.
comparison, right? Because I
Yeah.
was, in when I started doing this, none of these drugs were available as standard of care. So we've seen the before where we gave everybody chemo because we had nothing and chemo did nothing. And now
Mhm.
where we have drugs that are not only effective, but quite safe for a lot of patients.
Yeah, that's truly remarkable. So that was really great insight about what you're seeing. Is there any, recent data on these studies that you're able to reveal, or is it too soon to do that?
Well, I can't reveal anything from Ignite 3 because it's ongoing and we will just have to see. And that's really the confirmatory study for the earlier phase, which is done. But the study from the earlier phase, needless to say, was the data from the earlier phase was promising. Otherwise, you wouldn't be at phase
Right.
3. And what we had seen there, and I think 140 patients, don't hold me to that exact number, but I'm pretty sure that's it. We had seen about a 33% response rate, which it's a very dangerous game to compare trials to each other. So, but what I would say is the back of the napkin math is you have about a 1 in 3 benefit for a lot less toxicity than some other options that we have. And I really want to drive home the point that it is not infective to normal cells. There are no reports whatsoever of patients, caregivers, doctors, nurses becoming infected. And we also know that it appears to be quite safe and well tolerated. And then from an efficacy standpoint, one thing I really want to drive home, this is maybe where I really, really started paying attention, and I think where a lot of people in my field did as well. It's
Mhm.
when we understood that we were not just shrinking down the tumors that we injected, we were also shrinking down other non-injected tumors. We have never seen that to this extent with any oncolytic virus or oncolytic immunotherapy. And that's really powerful because it proves to us that there is a systemic response, systemic meaning in the body, in other tumors, not just in the injected tumor.
Absolutely. That is so encouraging and so exciting. So, since this is a phase 3 trial, it's not available to the public yet. A patient could not go to their physician and say, please prescribe this, right? They would have to ask their physician about the possibility of enrolling. Would you have any advice for a patient to ask of their physician, in order to see if they could get fast tracked on?
I would tell any patient to keep this in mind. And of course, nobody advocates for a patient better than themselves. And so an informed patient is the best patient, right?
Yep.
And to talk to their oncologist about the trial. And it is enrolling at many, many different centers. This is not a difficult trial to find a site to enroll on. And I have patients who don't like the randomization because even if you enroll on the trial, you have a 1 in 2 chance, excuse me, of getting the
Right.
investigational arm, which is RP1, the oncolytic immunotherapy plus PD-1. The other option is you're going to get investigator's choice, which is my decision on what to utilize from my armamentarium in the standard of care setting. And the options
Yep.
there really are Opdualag or relatlimab, nivolumab, chemotherapy, or anti-PD-1 by itself. And so most people in the US end up utilizing Opdualag. When patients are concerned about that, I really highlight two things to them. The first thing is that Opdualag is what I would be using anyway. If we don't go on trial, that's what I'm going to be doing.
Yep.
Because for reasons that we've already discussed on the call, or on our discussion. The other thing I tell every patient, and I tell myself all the time, of course, we go into trials with equipoise, meaning I don't go into the trial assuming I know the answer. I don't go into the trial assuming I know the outcome. I go into the trial trying to answer a very soundly designed I go into the trial, excuse me, trying to answer a question through a
Hmm.
trial that has been very soundly designed so that I have confidence in the conclusions of the study. So I tell the patient, yeah, we're all jazzed about RP1 and nivolumab, sure, but we are doing this trial to really prove what we think we know. I don't know it yet. And so I really take a lot of time to explain that to the patient because I get how it might concern people.
Absolutely. That's really great to know. Thank you for explaining that. I know, the choice to go on a trial is a big one for many patients, and sometimes it's their last opportunity to, try something new. And I think they need to feel really confident that they're doing the right thing. And it sounds like you really arm them with all of the information. So thank you for sharing all of that. Before we move on to questions and answers, do you have anything else that you would like to share about this trial, Dr. Najjar?
One thing I have thought about and I've been asked about is there is, as you may know, Dana,
Mhm.
um, a PDUFA date, which is in brief terms, we think that the drug itself may end up having approval in July, at the end of July. And I have patients asking me, well, what's going to happen with the study? The first thing that I tell patients is that just because something is approved, it doesn't mean it's going to be commercially available. We don't know the speed at which that's going to happen. And so it's very important that we keep driving enrollment for the study. But I also think it speaks to the rigor of the data that we have so far. And it's very important in oncology to have phase 3 trials because that's really the most rigorous way to answer a question. And I would just want to leave us with that takeaway.
Thank you. Really great information. I really appreciate that. All right. Well, I know we received a couple of questions from people that registered over the past few weeks. So maybe we can start with those, and then we can go to the live audience. Let's see, Renee, should I go
I'm
to the ones?
here. Yeah,
Hi. Should
I
I go
can
to
get us
the one?
started on the Q&A.
Okay, great.
Awesome. Yeah, so we did have a few come through with registration, as Dana had mentioned. And I'd like to start with, since Dr. Najjar just brought up the PDUFA date, a registrant had asked if this treatment were to be FDA approved, where do you envision RP1 sitting in the treatment sequence for metastatic melanoma patients, considering all the other available therapies, including immunotherapy, targeted therapy, TIL, etc.?
That's a great question and certainly one I spend a lot of time thinking about. So it is a second line option and one of few second line options I would add to that. So if a patient has gotten Ipi/Nivo frontline, I personally am really hesitant to go with relatlimab, nivolumab, or Opdualag second line. We have data showing that the response rate there is about 12%. So in other words, if you got Ipi/Nivo, I'm immediately thinking about utilizing this, which is RP1 and nivolumab. Now, if a patient has a BRAF mutation, per the clinical trial, you had to have utilized it first. So we'll have to see how that works out in the real world, whether or not we will sequence it that way. Most people in the field, most, if not all, melanoma oncologists feel very strongly that we would much rather sequence immunotherapies than utilize targeted therapy until we have to, because targeted therapy is not durable. The median progression-free survival for Columbus, which was a very big phase 3 trial, was about 14.9 months, which is very different than with immunotherapy. So I would see it sitting in the second line space, and when to use it depends on what the patient got first. If you got Ipi/Nivo, I'm probably thinking about this pretty quickly. If you got Opdualag or Rela/Nivo, I'm probably thinking about Ipi/Nivo second, and then considering this. So you can appreciate that a lot really depends on what was given first. Another thing I'm always asking myself is this patient appropriate for cell therapy or MTAGV or some variation of cell therapy in clinical trial? That is a very aggressive thing to do, and the window in which you can safely do it for a patient is usually pretty narrow. So I also think about that carefully on a patient by patient basis. Lastly, when we hopefully have approval for this, and of course I hope it'll be approved because it's always good to have options, I will still always have my eye on the next clinical trial because it is not lost on me at all that that's how we got here in the first place. It's by enrolling to clinical trials. The field will come to a dead halt if we don't keep doing that.
Absolutely. Thank you. That was a great answer. Renee, do
Yeah.
you want to serve up the next one?
Yeah, so question about tumor burden and how that comes into play when deciding who is ideal for this treatment or for the Ignite-3 trial. Is a lot of tumors, is that make them a better candidate? Does it make them maybe less of a candidate? And then you talked a bit about how injected tumors can have effects on non-injected tumors. So how does that all come into play?
That's a great question. I haven't thought about it in those terms, and I'll have to go back and look at the data breakdown for that to see whether patients with a higher tumor burden did worse. I certainly don't think that's the case offhand. I think about it as the patient's performance status, which is how are they doing clinically. if they have a lot of tumor, but they are okay, they are holding their performance status, meaning holding their function, they're holding their weight, their labs are holding, then I am much more set on that than the amount of tumor or the tumor burden that they have.
Awesome, thank you. You briefly mentioned side effects and how the treatment is really tolerable to patients, but I was wondering in more of a general sense, how are patients and side effects monitored on a clinical trial, and what certain multidisciplinary moves are made when patients are on a trial that may be different than just standard treatment.
Patients on clinical trials are monitored. I always tell every patient, I'm going to watch you like a hawk. And I really mean that. We watch them very, very closely. We do that in a very different way for a phase 1, which I'm also heavily involved in, which is first in human trials. Then we do it in a phase 3 trial. If a patient is enrolling on Ignite 3, I have a very good track record of safety, right? And of course, with each visit, which is every couple of weeks, I'm evaluating them from head to toe to make sure that I'm not missing anything. But by this point, with well over 100 patients dosed, well over, I'm quite confident in the safety signal. But they are assessed by physical exam, by review of systems, which is where we ask head to toe if they're having any symptoms, and by thorough lab panels, which are pre-specified.
All right, thank you. And then last question was brought up because of what you were discussing. Any thoughts as to why injecting deeper has better results?
Yes, I have my own thoughts. I don't know if it's true, but I have my hypothesis. For a tumor, melanoma in particular, to make its way from the outside, the skin, to the inside, it has to have overcome many, many different attempted halts by the immune system. At every juncture of tumor metastasis, and actually I presented some of this data from my lab at the last MRA meeting, at every juncture of metastasis, the tumor cell is different than it was before it came to that site. And so if a tumor is in the skin and then it goes to the lung and then it goes to the liver and then it goes to the brain, I can guarantee you that every one of those tumors is distinctly different. And I would argue with you, I would argue that the tumor that has made its way viscerally has a lot more mutations that are allowing it to survive in the host, in the patient, in spite of their immune system's best efforts, than a more superficial tumor.
Wow, that's fascinating. Thank you.
Really is.
That's it for the pre-registration questions, and thank you to anybody who submitted those when they registered. Anybody who's sitting here want to come off? Oh, I just got one. I just got a question from the chat, actually, an anonymous question. So, question about why uveal melanoma with mets to the liver are not eligible if liver tumors are large enough. So if a liver met is large enough, why is it ineligible? Because it's a uveal diagnosis.
I don't have an answer because I had nothing to do with the study design, is the short and frank answer. But I can tell you, I think it was excluded because we know that ocular melanoma is biologically very distinct from cutaneous melanoma. And what this trial is trying to answer the question of, and you really get one good question per trial, truly. This trial is trying to answer in patients with cutaneous melanoma for whom frontline immunotherapy has not worked, does this combination work? And we know that ocular melanoma is very different. What I will say, am I allowed to reference other ongoing trials? Dana, can we discuss the landscape with RP2? There's an RP2 trial.
I
Absolutely.
think you can touch on it. Yeah.
Okay, so for completion, I will tell you there is a clinical trial of RP2, which is also an HSV1 modified virus, and that's modified as well to be able to bind to CTLA4, which is one of the most primordial mechanisms of immunotherapy. And that's specifically for ocular melanoma. That's RP2 injections into the liver plus anti-PD-1. So that's a separate question. What I will say, going back to Ignite-3, is that mucosal is not permitted, and myself and many others have made our voices very loud and clear that we think that it should be.
That's great.
Thank
Well,
you.
yeah, we appreciate you advocating for everybody. That's fabulous. Is that it, Renee?
I haven't had anything else come through unless anyone wants to come off mute with any questions. And that last question was from Michelle. So thank you, Michelle, for your question. Anybody
Well,
else?
if that is it, we are so grateful to you, Dr. Najjar, for sharing your expertise and really taking a deep dive so that all of us can understand this incredible trial a little bit better. And we're so hopeful that everything, enrolls well and that we do eventually get that approval so that we have another weapon, to fight this cancer. So thank you. We'd love to also thank all of our participants. We appreciate your interest and your time. And we will make sure this recording is up on our Cure Melanoma website. So if you'd like to refer back or share it with others that may also be in the community and want to learn a little bit more, we would love for you to do that. Thank you again to the MRA team for making this possible, and we will see you all next time.
Thanks so much, Dana. Bye, everybody.
Bye. Thank you.